speaking French. So I'm just going to share my screen. So I hope this is better.
Did you see the arrow at the bottom of your screen? I think in a square you have an arrow, and you just have, I think, to click on that.
Yeah, that's what I'm clicking on. Hold on. Have you enabled sharing so I can share?
The button is not working for you?
Sorry, I'm really sorry about this.
No, it's okay.
Does it work? I just try to adjust.
If you want, you can send us the presentation and we'll share it from our account.
Yeah, maybe I should do that.
Yes, you can send it to Romain because you have his
I'm
email
sorry.
already. No, it's okay. Such things always happen. While we're fixing this technical problem, I want to say that this is a first experience for us with an English-speaking webinar. Usually all our webinars are in French, as their name is, the Francophonic webinars. And this is our first time for us to speak, all of us, in English. So we want to thank you, Dr. Jones, for accepting this experience to join us in this new adventure. And also we want to thank Dr. Terrier for being flexible and accepting to present in English. And also we thank all the participants for accepting to join us and to listen in English, because we know it's not that easy when you're learning and practicing medicine in a language and then switching to another one. Obviously, reading in English is not the same as speaking or listening to someone speaking in English. I think we're all in. Yeah, we made it. So.
I may have. I hope I've sent you the right presentation.
We will make it. No worry.
I may have sent you the wrong presentation, but shall we just start? Because I feel really bad for.
No, it's okay. It's okay. We can wait for like 2 minutes if that's what it's gonna take for you to send us the correct file.
Do you mind closing that one? Sorry. Yeah. I'm so sorry. I wonder if whether Professor Terrier should go first while I sort out my problems.
Yeah, I can, but I think I had the same issue than you, Rachel. So I send my presentation to Romain too.
Okay, all right. Okay,
I'm not able to share my screen neither. So So we are
Romain, if you want to share with me Dr. Terrier's presentation so that I project it while you work on Dr. Jones' presentation.
Yeah.
Hey, I'm sorry, I had too many things open at the same time.
No, it's okay. We will fix this.
And I just want to say, Professor Terrier, you can pop speak in French if that is better for the audience. I feel bad that you speak in English for me, and really I don't mind.
No, you know, I have to practice my English, so I think it's not so bad for me. But okay, you will tell us, the young internist, what you prefer.
Yeah.
Because French, speaking English to other French people, I think it's not so complicated to understand, because I have a French English, so that you will tell me.
I think we should go with whatever suits you the most, Dr. Terrier or Dr. Jones. So if you prefer speaking in French and Dr. Jones doesn't mind that, it's okay, I guess, for us. So whatever suits you the most.
Romain, you're supposed to have received my presentation. I don't know if it's the case on your email, but
yes, I received it. EGPA.
It's frequently like that with Teams. I don't know why. With Zoom, it's working quite well to share the screen, but okay. Okay, so I start, Rachel?
Yes, go ahead. And I've more or less got the right presentation now, but you go ahead.
Okay, so yeah.
Can you see it?
Yeah.
Okay. Okay.
But if you can put the full screen.
Okay.
And what do you prefer, French or English? I go.
Doesn't matter.
French.
French? Okay. Là, Romain, on ne voit pas en plein écran. Je ne sais pas si c'est pareil sur ton ordinateur.
C'est juste que c'est raccourci.
Super. Bon, ben, merci beaucoup. Merci en tout cas aux jeunes internistes pour l'invitation en tout cas, même si je me sens encore assez jeune. Donc, en tout cas, à parler de la granulomatose éosinophilique avec polyangéite, anciennement syndrome de Church-Strauss. Alors, si tu peux passer la diapositive suivante et même la suivante. Donc, comme vous le savez, la granulomatose éosinophilique avec polyangéite, qu'on appelait syndrome de Church-Strauss, est une vascularite des vaisseaux de petit calibre, telle qu'elle est définie dans la nomenclature de Chapel-Hill, et elle fait partie du groupe des vascularites ANCA. Rachel vous parlera beaucoup plus des deux premières, que sont la granulomatose avec polyangéite et la polyangéite microscopique. Et donc, moi, je vais vous parler de la granulomatose éosinophilique avec polyangéite. Diapositive suivante. Donc, c'est une pathologie qui a été décrite il y a maintenant 70 ans par deux personnes que sont Scherg et Strauss, que vous voyez en photo. Vous savez que si les noms des maladies, en tout cas les noms propres des maladies, ont changé dans les vascularites, c'était essentiellement suite à la demande un petit peu des vascularitologues et un peu d'associations de patients de se séparer du nom de Wegener qui était quand même associé de manière très claire au régime nazi. Et donc, a été, lors de cette révision de la nomenclature, eh bien, décidé de se passer quasiment de toutes les maladies éponymes et de les remplacer par une nomenclature qui était plus proche des constatations histopathologiques. Donc là, le syndrome de Sturge-Strauss est devenu la granulomatose éosinophilique avec polyangéite parce que c'était une vascularite nécrosante des vaisseaux de petit calibre, même si ça empiète un peu parfois sur les vaisseaux de moyen calibre, et qu'elle est riche en éosinophiles, comme on le verra après. Et en fait, on aura l'occasion d'en reparler, c'est en fait un asthme éosinophilique dans la plupart des cas, au cours duquel va se surajouter un tableau de vascularite qui va pouvoir toucher avec prédilection, en tout cas dans cette maladie, notamment le nerf périphérique, le cœur, la peau, et qui va faire tout un petit peu l'hétérogénéité de la pathologie. Diapositive suivante. Donc, globalement, la peau est probablement l'organe le plus rentable, puisque contrairement à d'autres formes de vascularite associées aux ANCA, le rein, on le verra, est assez rarement atteint. Le nerf périphérique est fréquemment atteint, mais quand même grévé d'une certaine morbidité, hein, avec notamment des zones d'hypoesthésie. Et donc la peau est vraiment un organe particulièrement important pour porter le diagnostic de vascularite, car l'atteinte cutanée survient dans environ la moitié des cas, et c'est souvent assez rentable. Et vous voyez par exemple cette lésion qui était d'allure purpurique, mais qui était aussi avec une nature urticarienne. Eh bien, vous voyez la présence d'une vascularite parce que vous voyez deux vaisseaux au milieu de l'image qui sont le siège d'une infiltration par des cellules inflammatoires, et on voit des cellules avec un cytoplasme plus rosé que sont les éosinophiles, qui qui permet de retenir un diagnostic de vascularite riche en éosinophiles. Diapositive suivante. Les critères de classification, assez brièvement, ils ont été ils ont évolué parce que initialement, vous savez, les critères de l'ACR de 90, on va reparler des nouveaux, avaient pour but en fait de distinguer les vascularites entre elles. Et donc la porte d'entrée dans ces critères de classification, c'était d'avoir une vascularite. Et donc chez un patient qui avait une vascularite, l'objectif était de trouver les items qui allaient permettre de distinguer une vascularite de type Sturge-Strauss à une vascularite de type, à l'époque, maladie de Wegener, et ainsi de suite. Et donc là, certains des items étaient retrouvés, donc qui sont notamment des choses importantes comme associées à la pathologie. Mais encore une fois, il fallait une preuve de vascularite, ce qui est souvent quelque chose qui manque dans cette maladie. Diapositive suivante, donc une étude dont on parlera, qui a été vraiment un petit peu l'étude qui a été la première à se concentrer de manière exclusive sur la GEPA, avait proposé, probablement pour faciliter les inclusions, des critères qui étaient quasiment des critères un peu diagnostiques, en tout cas des critères d'inclusion dans l'étude, où vous voyez que pour porter un diagnostic de GEPA, il fallait avoir un asthme, une hyperéosinophilie, et ensuite des manifestations qui étaient orientantes vers une vascularite, comme par exemple la neuropathie périphérique, les ANCA, et l'atteinte cardiaque ou rénale. Alors diapositive suivante. Et bien entendu, vous les avez peut-être vus, des nouveaux critères de classification. Donc on est vraiment dans de la classification, hein. Vous savez, ce n'est pas forcément utile au lit du patient, mais c'est notamment pour les travaux de recherche que vous auriez envie de faire. Désormais, il faudra que vous utilisiez ces critères de classification pour que les collègues un peu partout dans le monde, vous croient quand vous leur dites que vous avez une GEPA. Et donc là, maintenant, il faut quand même avoir chez un patient qui a un diagnostic de vascularite quand même, mais avec aussi des surrogates marqueurs de vascularite, comme le purpura, vous voyez des manifestations qui vont orienter vers une atteinte des voies respiratoires et qui donnent un poids massif aux éosinophiles, puisque vous voyez que la présence des éosinophiles à plus de 1000 donne 5 points, et donc c'est quasiment 80% du score dont on a besoin. Et je pense qu'il est toujours très important de rappeler qu'au sein des vascularites qui donnent des éosinophiles, en tout cas une hyperéosinophilie, certes il y a la GEPA, mais il ne faut jamais oublier que la granulomatose avec polyangite, anciennement maladie de Wegener, donne des éosinophilies qui peuvent être très importantes également. et également la périartérite noueuse, même si c'est quand même pas une maladie qui court les rues. Diapositive suivante, s'il te plaît, Romain. Donc, globalement, quand on regarde un petit peu les différentes séries de la littérature, eh bien, on peut voir que c'est une pathologie dont l'âge moyen au diagnostic est globalement d'une 50aine d'années, même s'il y a des extrêmes qui vont en gros de 18 à 85 ans. Vous voyez que l'asthme, mais c'était notamment un peu aussi à cause des critères de classification de l'époque, eh bien, était quasiment toujours présent. Donc, ça veut dire une chose, c'est que si vous voulez porter un diagnostic de GEPA chez un patient qui n'est pas asthmatique, il faut que vous ayez vos arguments. Et ensuite, l'atteinte ORL, vous voyez, c'est globalement dans 2/3 à 3/4 des cas que vous allez avoir une atteinte ORL dont la présentation la plus classique est la polypose nasosinusienne, exactement celle que vous pourriez voir, on va dire, comme pathologie fréquente ou notamment au cours de pathologies allergiques. Et il peut y avoir la présence parfois d'une rhinite croûteuse qui n'est pas forcément uniquement une manifestation de granulomatose avec polyangéite. Là, j'ai dû faire des petites animations que tu vas pouvoir passer, Romain, pour passer à la diapositive suivante. Alors, il y a des choses intéressantes à dire quand même sur l'asthme. L'asthme, comme vous le voyez sur ce graphique, l'objectif en tout cas du graphique du haut, c'est la ligne pointillée verticale, c'est le diagnostic de GEPA qui est posé. Et vous voyez que la ligne bleue, c'est la proportion des patients avant le diagnostic de GEPA. Vous voyez, moins 3 ans avant, moins 2 ans avant, moins 1 an avant, pour qui eh bien, leur asthme va justifier une corticothérapie orale, ce qui est quand même quelque chose qui n'est pas normalement quelque chose de très classique dans l'asthme banal. Et donc, c'est pour vous dire qu'en fait, quand on parle d'un asthme assez sévère corticodépendant, c'est pour vous dire que plus on approche du diagnostic de GEPA, plus la pathologie asthmatique semble difficile à contrôler. Avec des niveaux de prednisone, vous voyez qui avaient l'air d'augmenter, ça c'est les barres noires, d'autant plus de manière plus importante. Et au-dessous, vous avez le graphe qui est l'évolution des éosinophiles, et vous voyez qu'il semblait y avoir un début d'accélération de l'éosinophilie qui apparaissait dans l'année précédant le diagnostic de GEPA. Et donc tout ça pour dire que la GEPA survient généralement sur un asthme dont on a l'impression qu'on est en train de perdre le contrôle et les manifestations sont en train de progresser de manière importante. Et dans cette étude de l'équipe de Vincent Cotin, qui vous savez est à Lyon et coordonnait à l'époque un groupe qui s'appelait le GERMOP, eh bien en moyenne l'asthme évoluait depuis 12 ans, ce qui voulait dire que c'était un asthme qui était quand même assez ancien. Diapositive suivante, si on reprend les autres manifestations de la maladie, tu peux mettre mes petites animations. Eh bien, l'atteinte neurologique périphérique, vous voyez que c'est très fréquent, c'est quasiment 3/4 des malades sous la forme d'une polyneuropathie ou d'une mononeuropathie multiple. Pour l'atteinte cutanée, c'est, comme je vous le disais, au moins la moitié des patients. Et ça, c'est très important de le noter parce que ça peut donner la preuve histologique de la vascularite et l'infiltrat éosinophilique. Et je dirais que biopsie et une peau, la morbidité liée au geste est quand même quasi nulle. Et après, vous avez l'atteinte cardiaque, dont vous voyez une prévalence qui est très variable, essentiellement parce que si vous prenez les études anciennes, il n'y avait pas d'IRM cardiaque, il n'y avait pas forcément d'outils biologiques comme aujourd'hui. Et si on prend les études les plus récentes, on a l'IRM cardiaque qui surdiagnostique un petit peu les patients. Donc, diapositive suivante. Alors, il faut quand même noter que le cœur, c'est quand même un point majeur dans cette maladie, puisque la grande question est toujours de se dire, est-ce qu'il y a une atteinte cardiaque et est-ce que le poids thérapeutique va devoir être augmenté en raison de cette atteinte cardiaque? Et aujourd'hui, ce qui peut se discuter, c'est quels examens doit-on faire devant une GEPA pour suspecter ou pas une atteinte cardiaque. Et j'avoue que la stratégie, elle s'approche assez bien de ce qui est fait dans la sarcoïdose, une autre granulomatose, non éosinophilique celle-là. Mais c'est pour vous dire que si vous allez d'emblée à l'IRM cardiaque, vous allez probablement diagnostiquer des patients qui ont des signes imagerie en IRM, alors même qu'ils sont parfaitement asymptomatiques. Et donc, en gros, il faut se dire que l'IRM à tout va, c'est non. L'IRM, elle va avoir un intérêt surtout à viser pronostic si vous pensez qu'il y a une atteinte cardiaque. Et l'atteinte cardiaque, ça va être sur des éléments simples. Ça va être la clinique, une douleur thoracique, une cardiomyopathie avec insuffisance cardiaque. Ça va être des anomalies ECG, une dysfonction cardiaque en échographie cardiaque et des signes éventuellement de souffrance avec une augmentation de la troponine, par exemple. Et je vous rappelle que quand, par exemple, Loïc Guivin a développé le 5-factor score en 96, qui, vous savez, était un score et qui est toujours un score qu'on utilise, eh bien, croyez-moi qu'il n'y avait pas l'IRM cardiaque et que ce qui faisait dire que le patient avait une atteinte cardiaque, c'était avant tout la clinique. En tout cas, quand on fait une IRM, pour mieux préciser l'atteinte cardiaque, eh bien, on va pouvoir avoir plusieurs types de lésions importantes. Déjà sur les séquences T2, comme le montre la flèche, souvent un œdème myocardique qui montre un hypersignal en T2, ici au niveau du septum. Diapositive suivante. On va pouvoir avoir sur les séquences en T1, après injection de gadolinium, vous savez qu'on peut faire des acquisitions d'images précoces et des acquisitions plus tardives. En tout cas, au niveau des acquisitions précoces, on va pouvoir voir, comme vous le voyez au niveau des flèches, avec vraiment des prises de contraste précoces dans le muscle cardiaque, dans le myocarde. Et vous pouvez voir que c'est transmural, aussi bien au niveau sous-épicardique que sous-endocardique ou intramyocardique. Diapositive suivante. Et bien entendu, ce qui est l'élément peut-être le plus fort, notamment quand on regarde et qu'on appréhende les myocardites, c'est la prise de contraste tardive, ce qu'on appelle les LGE dans la littérature, en tout cas anglo-saxonne. Et là où vous pouvez voir aussi, aussi bien des lésions sous-endocardiques ou sous-épicardiques. Alors la diapositive suivante, elle a pour but de montrer un peu tous les patterns que l'on peut voir. Et ce qu'il faut voir avec la GEPA, c'est que c'est une maladie assez fascinante parce qu'elle associe la granulomatose, donc avec les localisations préférentielles des granulomes, comme on voit dans la sarcoïdose au niveau du septum, par exemple sur l'item, le panel B. On peut voir des lésions dues aux éosinophiles, avec, vous savez, la toxicité endothéliale et donc de l'endocarde par les éosinophiles, comme on peut voir au niveau du panel A. Et puis, on peut voir également des lésions de vascularites qui sont plus sous-épicardiques, donc vous savez, à l'extérieur du muscle cardiaque, comme on voit par exemple sur le panel C. Et donc, c'est pour vous dire que la GEPA, c'est un concentré de tout ce que les pathologies éosinophiliques, granulomateuses et inflammatoires peut donner. Et donc, c'est très riche et donc c'est en IRM l'ensemble des paramètres que l'on peut voir. Alors, diapositive suivante. Et donc, si on résume, comme je vous le disais, c'est avant tout un âge médian de 50 ans, autant les hommes que les femmes. Et là, Romain, si tu peux mettre de manière progressive, vous voyez une éosinophilie sanguine qui est quasiment toujours présente et qui pourra ne pas l'être si votre patient, par exemple, sort d'une corticothérapie mise par son médecin traitant pour une décompensation de son asthme. Donc ça, à savoir, mais sinon, l'éosinophilie, elle est toujours présente. L'asthme, c'est des critères après, des histoires de classification, mais c'est 90% des malades. Dans la littérature, en moyenne, c'est un asthme qui évolue depuis 3 à 9 ans, mais donc c'est pour vous dire, ce n'est pas un asthme tout neuf. Suivant, l'atteinte de la sphère ORL à type de polypose nasosinusienne, voire plus rarement de croûte nasale, ça se voit dans 2/3 des cas. Ensuite, la neuropathie, c'est la moitié des patients. Ensuite, la cardiomyopathie, les ANCA et la cardiomyopathie, c'est 1/3 des patients. Idem pour le cœur. Donc, ce que ça veut dire, et ça, je vous donne juste ça parce que c'est quasiment un élément avec les avis que l'on reçoit, où l'absence d'ANCA est souvent un élément qui gêne les cliniciens à porter un diagnostic de GEPA. Mais ce qu'on peut voir à partir de là, c'est que la majorité des GEPA n'ont pas d'ANCA. Et donc, j'ai envie de dire, ce qui est le plus atypique dans une GEPA, c'est d'avoir des ANCA, puisque c'est que 30%. En tout cas, cette spécificité anti-myéloperoxydase. Le cœur, c'est un malade sur 4, globalement. Et ensuite, ce qui est très rare, dans moins de 10% des cas, dernière petite animation, Romain, c'est l'atteinte rénale, la rapidly progressive glomérulonéphritis dont Rachel vous parlera, qui est vraiment très proche de ce qu'on voit dans les autres vascularites ANCA. C'est une glomérulonéphrite extracapillaire post-immune, mais qui est présente très rarement dans moins de 10% des cas. Diapositive suivante. Ce qui a été objectivé depuis maintenant vraiment les papiers initiaux, soit les études italiennes comme celle de Sinico, l'étude française, celle de Sablé-Fourtassou, c'est qu'il y avait quand même un peu une prédominance de certaines manifestations selon qu'il y ait ou pas des ANCA ou pas d'ANCA. Et donc, classiquement, l'absence d'ANCA était associée à l'atteinte cardiaque, alors que la présence d'ANCA anti-MPO était associée à des manifestations dites vascularitiques, comme on verrait dans une polyangite microscopique, avec notamment l'atteinte du rein, la mononeuropathie multiple, le purpura. Après, dites-vous bien que des patients avec des ANCA ont des atteintes cardiaques et des patients sans ANCA peuvent avoir une atteinte neurologique périphérique. Donc, cette distinction qui sortait sur des effectifs importants, si vous voulez, ce n'est pas tout blanc, tout noir. Et donc, il ne faut pas se faire piéger, se limiter, par exemple, uniquement à rechercher l'atteinte cardiaque quand les malades n'ont pas d'ANCA. Et à l'inverse, se dire qu'il faut aller encore plus loin dans la recherche d'une atteinte cardiaque parce que le patient n'a pas d'ANCA. Diapositive suivante. Alors, concernant la prise en charge, puisque c'était notamment ça la question un petit peu, eh bien, comme je vous le disais, la prise en charge, mais qui reste encore d'actualité, celle qu'on pourrait appeler celle avant l'ère des biologiques, eh bien, elle repose sur ce score que Loïc Guivin a développé il y a maintenant 25 ans, qui est le 5 Factor Score, qui retenait 5 items qui impactaient négativement la survie, donc le pronostic vital. Et donc, chez ces patients, avec ce score qui a été développé spécifiquement dans la GEPA et dans la périartérite noueuse, eh bien, les patients qui n'avaient pas de facteur de mauvais pronostic recevaient un traitement par des corticoïdes seuls, avec une durée généralement de 18-24 mois, et les patients ayant un facteur de mauvais pronostic, ce qui représente environ un tiers des malades, eh bien, étaient traités plus lourdement, puisqu'ils étaient plus à risque de mourir, avec une induction par corticoïdes associée à des perfusions de cyclophosphamide, l'endoxan, avec un relais derrière par des immunosuppresseurs conventionnels, à savoir l'azatioprine et le méthotrexate généralement. Mais vous voyez que le pronostic à long terme des patients recevant ce schéma, qu'on pourrait appeler, je ne sais pas, old school ou juste voilà, non avant l'ère des biologiques, eh bien vous voyez que même si la cortisone marche très bien pour obtenir la rémission, seulement 30% des malades ont une rémission prolongée, que quand on se place à environ 6-7 ans du diagnostic, la majorité ont encore des corticoïdes et donc ils ont des séquelles avec soit les séquelles liées à la corticothérapie, soit les séquelles liées à la maladie, comme par exemple l'asthme chronique ou l'obstruction nasale. Donc très clairement, on peut dire que les corticoïdes, quand on les donne, ils marchent bien, mais c'est une maladie dont on n'arrive pas à se passer des corticoïdes. Et si vous vouliez voir à quoi ressemble un syndrome de Cochin, dans un service de médecine interne, en tout cas, qui prenait en charge les vascularites, c'était très clairement les patients avec une GEPA qui étaient beaucoup plus les illustrateurs vraiment majeurs de ce qu'étaient, on va dire, les complications de la corticothérapie qu'une polyangite microscopique ou une granulomatose avec polyangéite. Diapositive suivante. Donc est arrivée l'ère des thérapies ciblées et aussi dans la GEPA, même si c'était probablement la pathologie dans laquelle c'est arrivé le plus tardivement au sein des vascularites à ANCA. Alors, comme c'est une maladie pour laquelle l'éosinophile est centrale, diapositive suivante, eh bien, le mépolizumab, traitement ciblé, ciblant l'interleukine 5, un anticorps monoclonal, a été logiquement au cœur des préoccupations. Alors, diapositive suivante. Et donc, à la suite de 2 études de petite taille prospective, a été conduite une étude qui était la première étude qui a utilisé les critères un peu dont je vous parlais tout à l'heure, un petit peu pratiques, qui était le premier essai prospectif randomisé contrôlé spécifique de la GEPA. Eh bien, c'est l'étude du New England de 2017, qui était un essai randomisé contrôlé contre placebo en double aveugle, où les patients qui avaient une maladie en rechute ou réfractaire étaient randomisés entre recevoir 300 mg par mois de mépolizumab, c'est 3 fois la dose utilisée dans l'asthme, dont l'AMM est de 100 mg par mois, versus un placebo pour 52 semaines. Diapositive suivante, Romain. Quand on regarde, et également juste ma petite animation, la suivante, quand on regarde juste avant, le profil des patients, vous voyez que c'est des patients qui ont peu d'ANCA, parce que c'était des patients qui, au moment de l'inclusion, souvent n'avaient plus d'ANCA positif. Vous voyez que c'est des malades qui avaient leur maladie depuis 5 ans en moyenne et qui avaient un taux d'éosinophile normal et une dose de corticoïdes bloquée à 12 ou 11 mg. Donc, ce que ça veut dire, c'est que ces patients, c'était ce qu'on appellerait aujourd'hui une GEPA vieillie, en tout cas, ou une GEPA corticodépendante, pour lequel on était dans l'impossibilité de baisser la corticothérapie, essentiellement à cause de l'asthme et ou les manifestations ORL. Donc, cette étude, elle n'évalue pas, en fait, ce que donne le mépolizumab sur une poussée de vascularite cardiaque, sur une poussée de vascularite dans le nerf. Donc, elle traite en gros les asthmes et manifestations ORL de la GEPA quand on est loin du diagnostic. Diapositive suivante. Alors, ce que ça montre sur le panel de droite, c'est que de gauche, pardon, c'est que quand on regarde au cours du temps, la proportion des patients qui atteignent une rémission, atteindre une rémission, c'était la possibilité de baisser la corticothérapie à moins de 4 mg par jour. Eh bien, vous voyez que le mépolizumab, il fait beaucoup mieux que le placebo. Il n'y a pas photo. Mais vous voyez aussi qu'il y a 2/3 des malades qui n'atteignent pas l'objectif. Donc, c'est pour dire que le mépolizumab, il a l'air de bien faire, mais il y a de la place encore pour mieux faire. Et quand on regarde au cours du temps la survenue d'une rechute de la GEPA, que ce soit une rechute d'asthme ou de vascularite, eh bien, vous voyez que l'incidence cumulée, la proportion cumulative, est beaucoup plus importante dans le groupe bleu qui est le placebo que le groupe rouge. Donc tout ça pour dire, diapositive suivante, que quand on regarde les critères de jugement primaire et secondaire, ben le mépolizumab, il éclate le placebo sur ce groupe de patients. Et donc, ben, ça offre une thérapeutique qui a l'AMM depuis décembre 2021 en France, avec actuellement une négociation du prix pour définir ben, quel est le prix qui va être utilisé. Diapositive suivante. Alors, ouais, pardon, vas-y, tu peux continuer. Alors, globalement, comme vous le savez peut-être, en France, on a été dans l'impossibilité pendant un temps d'utiliser cette dose de la GEPA à 300 mg. Pourquoi? Parce que la seule dose qui avait une AMM en France, c'était la dose de l'asthme à 100 mg. Donc avec une interne italienne, on avait, et les Italiens ont refait la même chose derrière et qui montrent la même chose, c'est qu'on a voulu essayer de comparer de manière purement rétrospective que donnait le mépolizumab à 100 mg versus le 300 mg, parce que certains centres en Italie pouvaient utiliser 300 mg et en France ou dans d'autres pays d'Europe 100 mg. Et vous voyez que quand on regarde sur l'effet d'épargne cortisonique, on a l'impression qu'à 12 mois, ça ne changeait pas grand-chose. Animation suivante. Et quand on regarde cette fois-ci en termes de réponse globale, la rémission, la capacité de descendre à moins de 5 mg les corticoïdes, la réponse, la capacité d'être avec une maladie contrôlée entre 5 et 10, vous voyez que c'est globalement kiff-kiff. Tout ça pour dire que, comme on a été habitué à utiliser 100 mg, aujourd'hui, si vous demandez autour de vous, aux gens, eh ben, qu'est-ce que vous feriez maintenant qu'on va pouvoir avoir le mépolizumab à 300 mg, eh bien, certains vont vouloir commencer à 100, d'autres vont vouloir commencer à 300 parce que c'est l'AMM. On avait voulu faire un essai de non-infériorité du 100 mg par rapport aux 300 mg avec un financement académique au PHRC. Et malheureusement, pour l'instant, on n'a pas pu encore le financer, mais c'est pour dire que c'est une vraie question. Diapositive suivante. Quand on regarde ce que donnent d'autres thérapeutiques de l'asthme, comme par exemple l'omalizumab, qui était présent dans le marché du traitement de l'asthme ou même des atteintes ORL bien avant le mépolizumab, eh bien, vous pouvez voir que l'effet d'épargne cortisonique de l'omalizumab en vert par rapport au mépolizumab en rouge est nettement moins bon, ce qui fait que très clairement, quand un traitement de l'asthme s'impose dans la GEPA, c'est les anti-L5, point barre. L'omalizumab, ça ne marche pas bien et en plus, on avait observé que ça pouvait être à l'origine de poussées de vascularite. Diapositive suivante. Et donc là, quand vous avez un patient qui a un asthme corticodépendant ou des manifestations ORL corticodépendantes, diapositive suivante, et qu'on est face à une corticothérapie à plus de 7,5 mg par jour, c'était les critères d'inclusion dans l'essai. Diapositive suivante, la première chose à faire, c'est vérifier que vous n'avez pas des éléments qui déstabilisent votre asthme, à savoir un reflux gastro-œsophagien non traité, éventuellement plein de moisissures au-dessus de votre lit, une intolérance aux AINS et pourtant vous en prenez. Ça, c'est ce que font les asthmologues tout le temps face à tout asthme, mais il ne faut pas déroger à la règle quand on prend en charge une GEPA. Il faut vérifier que votre malade prend bien ses inhalateurs pour l'asthme. Un asthmatique sur 2 dans une consultation d'asthmologie ne prend pas bien ses bêta-2. Et vous voyez peut-être pour certains des QR codes maintenant qui apparaissent quand vous prescrivez un inhalateur sur vos ordonnances à l'hôpital. Et bien, si vous captez le QR code, ça vous envoie sur une plateforme qui s'appelle Zephyr, qui a été faite par la Société de pneumologie de langue française et qui, pour chaque inhalateur, vous explique et explique aux patients comment le prendre. Et enfin, il faut en théorie passer à la trithérapie inhalée en ajoutant les anticholinergiques. Ensuite, si malgré ça, vous avez un asthme mal contrôlé ou des manifestations ORL, diapositive suivante, eh bien, il faut considérer la mise sous anti-IL5. Et la diapositive suivante, vous allez passer en réunion de concertation asthme, c'est les RCP des asthmologues, et vous allez vérifier que votre asthme est mal contrôlé, refaire des EFR, refaire un scanner thoracique pour vérifier que vous n'êtes pas en train de rater quelque chose. Et ensuite, diapositive suivante, considérez la mise sous mépolizumab avec, comme je vous l'ai dit, 2 doses qui s'offrent à vous. Une dose qui est plus celle qu'on a été amené à utiliser en pratique, qui était le 100 mg, mais une dose qui est celle de l'AMM, qui est celle du 300 mg, et donc pour lequel il est difficile sur des éléments solides de dire aux gens faites comme si, sauf qu'on a généralement envie de se calquer sur les données evidence-based, à savoir donc le 300 mg. Diapositive suivante. Alors, on est en train d'évaluer dans le cadre d'un essai thérapeutique ce que donnerait le mépolizumab à la phase aiguë de la vascularite, non pas à 5 ans de suivi, mais à 1 semaine de suivi d'une GEPA, et en s'opposant à la stratégie conventionnelle. Ça, c'est un essai académique qui s'appelle Émerge, et dont peut-être certains centres français dans lesquels vous êtes vont participer. Diapositive suivante. L'autre vraiment auquel on peut se poser la question, c'est le rituximab. Pourquoi? Parce qu'il y a quand même dans un tiers des cas des ANCA, parce que Rachel va vous en parler, le rituximab dans la GPA et la MPA, c'est quand même un traitement majeur, et que la GEPA, c'est quand même une cousine des 2 autres. Et donc, très clairement, le rituximab, la question se pose de sa place. Diapositive suivante. Et donc, ce qu'on peut dire, c'est que des essais rétrospectifs, des données, on va dire, des études rétrospectives ont été faites sur des nombres limités de patients, avec ou sans ANCA, et que ce que l'on peut dire, c'est que ça avait l'air de marcher pas trop mal en combinaison avec la corticothérapie qui était prescrite, et avec l'impression que le rituximab faisait peut-être mieux quand les malades avaient des ANCA que pas d'ANCA. Diapositive suivante. Par exemple, quand vous regardez ce qui caractérisait les malades qui étaient généralement traités par du rituximab, vous voyez qu'il y avait un score BIVAS, qui est le score d'activité des vascularites, qui était très élevé, on va dire, par rapport à un asthme. Vous aviez des atteintes d'organes où il y avait du rein dans 24% des cas, de la peau dans 49% des cas. Donc, on avait vraiment un profil des patients qui n'était pas le même que ceux des essais mépolizumab. Donc, tout ça pour vous dire que quand on analyse un petit peu ce que peut donner le rituximab, ce que peut donner le mépolizumab, il ne faut jamais oublier de regarder comment était la population de l'étude. Et donc, les données qu'on avait dans le rituximab, c'était avant tout chez des patients qui avaient une authentique vascularite réfractaire et non pas juste un asthme qu'on avait du mal à contrôler. Diapositive suivante. Les Italiens, tu peux encore avancer d'une, ont également regardé en entretien ce que ça pouvait donner par analogie avec ce que Rachel vous présentera peut-être, c'est-à-dire les données sur le rituximab en entretien, et montré que quand on donnait ligne pleine du rituximab tous les 6 mois, comme on fait dans les autres vascularites, par rapport à ligne pointillée, pas de rituximab d'entretien, et vous voyez en termes de survie sans rechute sur le panel de droite, on a l'impression que c'est le jour et la nuit. Et donc voilà, donc tout ça commençait à donner des éléments en tout cas pour se dire il faut peut-être évaluer les choses prospectivement. Diapositive suivante. Et c'est ce que le groupe français a fait avec un essai qui s'appelle l'essai REOVAS pour rituximab dans les vascularites eosinophiles, où on s'est comparé le rituximab à l'endoxan ou à la corticothérapie seule chez les malades ayant un score, un 5-factor score qui n'était pas, on va dire, sévère, et en tout cas qui s'est comparé à la stratégie conventionnelle. Diapositive suivante. Ce qu'on peut dire, c'est que vous voyez qu'il y avait donc 105 malades qu'on a inclus dans cet essai prospectif en double aveugle, des malades nouvellement diagnostiqués, des malades rechuteurs, des patients qui avaient une maladie grave, FFS super 1 dans environ 40% des cas, d'autres avec une maladie non grave dans 60% des cas, et environ un peu plus de malades n'ayant pas d'ANCA que des malades avec des ANCA. Diapositive suivante, quand on regarde le critère de jugement principal qui était l'absence d'activité de la vascularite, donc un BIVAS à 0 avec une corticothérapie à moins de 7,5, vous voyez qu'on ne retrouve aucune différence entre les 2 bras. Et ce qu'il faut signaler, c'est que c'était un essai, essentiellement pour une histoire de calcul du nombre d'effectifs, de supériorité du rituximab par rapport à la stratégie conventionnelle. Et donc, si vous voulez, eh bien, vous voyez que le petit p n'est pas significatif, donc le rituximab n'est pas supérieur à la stratégie conventionnelle. Donc, c'est un essai négatif. Vous pourriez dire, oui, mais les pourcentages, ils ont l'air d'être identiques entre les deux bras. Oui, on peut le dire, mais ce n'est pas un essai de non-infériorité, donc ce n'est pas un essai qui, à la fin, a le droit de dire les deux stratégies sont identiques. Donc, à la fin, ce que ça veut dire, c'est que le rituximab a échoué à être mieux que la stratégie conventionnelle et que donc la stratégie conventionnelle reste la stratégie de première ligne face à une GEPA. Il n'empêche que ce qu'on peut se dire, c'est que chez un patient pour lequel la stratégie conventionnelle poserait problème, notamment l'endoxan, chez un patient en âge de procréer, à qui on ne peut pas faire de préservation ovarienne, eh ben, que faire du rituximab, ce n'est probablement pas la cata. Diapositive suivante. On a essayé de regarder ensuite ce que donnait la survie sans rechute en aveugle des bras par un comité d'adjudication. Et on a vu qu'il n'y avait aucune différence et c'était exactement pareil qu'on se concentre sur les ANCA+, ANCA-, les graves ou les pas graves, les rechuteurs ou les pas rechuteurs. Tout ça pour dire que le rituximab chez les graves peut être une stratégie alternative à l'endoxan, mais qu'en revanche, chez les non graves, ça n'a l'air de ne rien apporter par rapport à la corticothérapie seule. Diapositive suivante. Et donc aussi en entretien, pour essayer de voir si ce que voyaient les Italiens, c'est vrai ou c'est pas vrai, eh bien, il y a un essai en entretien qui se compare à la stratégie conventionnelle qui est en cours, qui s'appelle Menritseg, dont on attend les résultats dans 2 ans, puisque toutes les inclusions sont terminées. Diapositive suivante. Donc pour terminer, pour vous dire comment intégrer tout ça et dans votre pratique. Alors, il y a des recommandations de l'ELAR à laquelle j'ai eu la chance de participer qui vont sortir là, très prochainement, qui sont sous presse et qui disent ceci. Pour induire la rémission de la GEPA chez les malades qui ont une atteinte sévère, une atteinte fonctionnelle d'organes ou mettant en jeu le pronostic vital, vous voyez que le gold standard reste la combinaison corticoïde-endoxan et essentiellement, comme je vous l'ai dit, parce que Réovas est un essai négatif. En revanche, il est signifié, grâce aux données françaises, que le rituximab peut être considéré comme une alternative. Diapositive suivante. Quand on est face à un traitement, diapositive suivante, ouais. Quand on est face à un patient qui n'a pas d'atteinte sévère, ce que l'on peut considérer comme étant un patient avec un FFS 0, eh bien vous voyez que les corticoïdes restent la première ligne, puisque dans notre étude Réovas, corticoïdes plus rituximab ne faisait pas mieux que corticoïdes seul. Donc ajouter du rituximab dans ce groupe n'a pas l'air d'apporter le moindre bénéfice. Diapositive suivante. Que faire chez les patients qui ont une maladie en rechute ou réfractaire, ceux qui étaient l'intitulé, entre guillemets, du New England avec le mépolizumab? Eh bien, les collègues anglo-saxons, européens ont fortement poussé pour qu'on utilise le mépolizumab en, en traitement préférentiel, mais je veux juste insister sur le fait que ce qu'ils appelaient des malades relapsing ou réfractaires, c'était ces malades qui étaient surtout corticodépendants pour l'asthme ou les manifestations ORL. Diapositive suivante, et que pour le maintien de la rémission, ça, on était, mais vous voyez, c'est comme ça que se passent les recommandations. On est 25 experts, tout le monde donne une note de 0 à 10. 10, c'est si on est en accord. Eh bien, ça a eu une note d'environ 8,5 sur 10, de dire que pour l'entretien, on pouvait mettre soit métaux, soit azatioprine, soit mépolizumab, soit rituximab. Autant dire c'est tout et rien, alors que, par exemple, Menritseg a pour but de définir le traitement par rituximab, et que vous aviez, entre guillemets, 2 Gaulois qui avaient mis 5 sur 10 à cette recommandation-là, c'était Loïc Guivin et moi-même, pour dire que globalement, cette recommandation de maintien de la rémission, elle repose, contrairement à beaucoup d'autres des recommandations qui ont été faites, pas du tout sur du donné evidence-based, et que donc, ça nous embêtait un peu, mais c'est pour vous dire que là, le chapeau est très ouvert. Diapositive suivante, ça reflète un peu ce que je vous ai dit. Je pourrais bien entendu partager le diaporama. Et diapositive suivante, et bien là également pour l'entretien, ce que je vous ai dit. Et donc ça, c'est les recommandations qui vont sortir. Donc pour conclure, dernière diapositive, eh bien, Aujourd'hui, le FFS, même si vous le verrez, peut-être que Rachel vous en parlera, on ne l'utilise plus même en France dans la GPA et la polyangite microscopique, mais il reste d'actualité au niveau européen pour le traitement de la GEPA. Eh bien, il permet de stratifier les malades, que la stratégie conventionnelle, elle fait pas mal, mais clairement, elle est associée à des effets secondaires de la corticothérapie, des séquelles de l'asthme, que clairement les biologiques, que ce soit le mépolizumab ou le Ritux, ils ont une place qui reste un peu à mieux définir, qui est bien définie pour certaines d'entre elles, mais pas toujours. Et qu'enfin, quand même, s'il y a un traitement qui aujourd'hui a le plus de niveau de preuve dans les biologiques, c'est clairement le mépolizumab. Mais encore une fois, je ne peux que vous encourager à vouloir inclure dans les études, notamment quand on se pose la question du mépolizumab à la phase aiguë, qui encore une fois n'a pas été, à mon sens, bien évaluée. Donc voilà ce que je voulais vous dire pour la GEPA et je suis à votre disposition pour répondre. Alors je ne sais pas si vous voulez que ça soit après la présentation de Rachel et maintenant, mais je me plie à ce que vous voulez.
Question à la fin de la présentation. Ça vous convient?
Ouais. I hope with the slides in English, Rachel, you were able to follow the talk.
We can't hear you.
Sorry, it was a really great talk. Yeah, it was great. I think the you really nicely highlighted the cardiac involvement, which is so important to appreciate for anybody who's not looking at vasculitis patients every day. It can be quite subtle in clinical practice, and you really have to measure troponins and look for it very hard, and then you find it much more than you would if you don't look. It's a big problem.
No, I totally agree that troponin, in fact, it's really less expensive than MRI, and clearly it's really effective to identify the patients with myocarditis as the electrocardiogram. So it's clearly something that should be done clearly in every patient with EGPA. And that's why for the young internist, maybe you saw the recent recommendation in sarcoidosis, for instance, and cardiac sarcoidosis, and it's quite very similar. So you have to start first with the basics, and after, just in case you have any doubt or evidence for an involvement, you move to the MRI. But the risk to do the MRI in every patient is like in sarcoidosis to highlight some lead gadolinium enhancement, some lesions for which you don't know if they are prognostic or not.
And I think, I mean, it is very obvious when someone has neuropathy or asthma. These are, if you don't find the cardiac involvement, it really does change the way you treat them. As you've said, you talked about just using prednisolone for non-severe disease, where it would, immediately put patients into a severe disease category, needing cyclophosphamide, and it really does make a big deal of difference in terms of how you treat them, doesn't it?
Yeah, totally agree. That's true that, in the 5-factor score, which is mainly represented by some renal items, as the central nervous system, the heart, and the gastrointestinal involvement. In fact, in the setting of EGPA, the kidney involvement is very rare. So the heart is really one of the main reasons to give more aggressive treatments. The gastrointestinal can be occurred too. And maybe what it was always a question, and it was true also when we were still using the 5-factor score in France. And Rachel, I was talking to them that in France we moved and we get rid of the 5-factor score for GPA and MPA to be more in line with the UK, with the US, because clearly peripheral neuropathy was not in the FFS because it was not a life-threatening manifestations, and clearly it's sometimes very severe, and it was sometimes very confusing for people in France, you know, to not give aggressive treatments because it was not in the 5-factor score, but it was very severe. So that's why we keep the FFS in eGPA.
Yeah.
Je crois voir une question dans le chat. Patient jeune atteint d'une GEPA sans asthme avec atteinte cardiaque, coronarite, protéinurie, 9 cures de cyclophosphamide avec bonne évolution et résolution. Donc, pardon. Mais persistance d'une protéinurie à 3 grammes, est-ce qu'on considère comme une réponse incomplète? Est-ce qu'on passe au rituximab ou bien c'est une atteinte séquelaire? Alors, c'est assez intéressant le rein dans la GEPA parce que, en fait, on peut avoir des tableaux de glomérulonéphrite rapidement progressive qui vont généralement avoir une hématurie et généralement une protéinurie qui n'est pas néphrotique du tout. C'est généralement des néphropathies, des protéinuries de l'ordre du gramme. Et avoir une atteinte rénale séquelaire avec 3 grammes de protéinurie, peut-être pas d'hématurie, ça fait se poser la question en tout cas que l'atteinte rénale puisse être due à de la glomérulosclérose un peu terminale, voire même à d'autres patterns. Et il y a eu un travail coordonné par Cécile Audrey-Durel, qui est interniste à Lyon, et Alexandre Carras, qui est néphrologue à Paris, qui avait montré que dans ces tableaux éosinophiliques, une des atteintes qu'on pouvait voir dans la GEPA, c'était les glomérulonéphrite extramembraneuses. Donc devant un tableau comme ça, clairement, la chose à faire, c'est une biopsie rénale. Parce qu'il faut comprendre à quoi est due cette protéinurie persistante. Est-ce qu'elle est due à des lésions séquelaires? Est-ce qu'elle est due à une maladie active? Et ça, c'est la biopsie rénale qui peut vous le dire. Et clairement, ce qu'on sait des protéinuries dans les vascularites à ANCA, c'est que les protéinuries de haut niveau, elles sont prédictives d'une évolution vers l'insuffisance rénale terminale. Et aujourd'hui, en 2022, vous avez les IEC, vous avez les glyphosines, et vous avez en gros des traitements qui permettent d'être vraiment des antiprotéinuriques majeurs. Et donc, clairement, il faut, parce que clairement, le rituximab sur une atteinte séquelaire eh bien, n'aurait pas sa place. Donc, ne pas hésiter à biopsier le rein pour savoir où on va.
I have a question regarding the place of rituximab. If we see the latest recommendation of the American College of Rheumatology, we see that rituximab still have its important place in the management of GEPA, especially in the induction remission, in the remission induction. While in your presentation, Dr. Terrier, we don't see the rituximab showing. So what do you think? Does rituximab really have a place in the management of GEPA or not?
So clearly, we were very confused when we saw the SCR recommendation for eGPA. I think for GPA and MPA, but Rachel, maybe we'll talk about that. From the French point of view, we were quite in line with that, but we are really not in agreement with the recommendation of eGPA, and especially because they didn't know at all the results of the REOVA study. So in fact, when you look at the text from that, they said, we don't have any evaluation of rituximab compared to cyclophosphamide, so we say that people can receive both. So it's something that it's not usually what we do in recommendation, for which we are mainly based on evidence-based recommendation, but we also have to see that in the US, because of the reimbursement, it's very important for people, from practitioners, for patients, to be, able to use this strategy. And so I think there was clearly, the potential impact of the reimbursement, since the healthcare system is different. Clearly, in the EULA recommendation, and Peter Merkel from the VCRC and the SCR was there, clearly we were more in line with the REOVAS results. So it means that the first line in severe patients is cyclophosphamide, but if you have a patient for which cyclophosphamide is contraindicated or we don't want to give it, clearly rituximab could be an alternative. So both regimens could be used, but clearly there is more evidence to use more cyclophosphamide than rituximab, but you can do it. So that's why I think we have to see like that. And so far in the EULA recommendation, we didn't use the ANCA results to orientate the choice of the treatments. But what I can say is that with a fellow that we have, which is called Martin Duterte, which is a French young internist, the long-term follow-up of Reovas will provide additional information that would maybe change the practice in the next months.
Okay, really clear. I don't know if you have any other questions in the audience. Before we give the floor to Dr. Jones, I will check in the conversation. If you have any questions, you can type them. I invite everyone to type their questions.
There is one.
We have a question.
Yeah, in the
about
chat
the place of imatinib.
Yeah, about tyrosine kinase inhibitors, the imatinib that is used in HES, hypereosinophilic syndrome. There is only maybe 2 case reports in the literature about the use of imatinib. And I think, but it's always the case with case reports. You report only when it's successful. So I think there is no room for imatinib and tyrosine kinase inhibitors in EGPA. I think today with the anti-IL-5, we have enough strategies. What we can say is that in the literature, there is maybe only 2 or 3 cases in which we found the fusion gene, like in HES, in a patients with EGPA. Of course, if you find the mutations, the fusion gene, you could use imatinib, but I think it's not. We don't have to use it at all, and it's not in any of the recommendation.
I don't see another question. I invite everyone to write their questions, maybe the presentation. After we finish the talks, we can go back, get back to the questions if Dr. Terrier will be still available to answer more. So I invite Dr. Jones now to, I give her the floor to talk about the management of GPA and MPA. The floor is yours, Dr. Jones.
Thank you very much. Thank you. So I was just, so if you go on to the next slide, thank you. So that was a great presentation we just heard about eGPA. And what I was going to do is talk quite a lot on treatment of ANCA vasculitis and our challenges. We have quite a good evidence base for MPA and GPA due to the number of clinical trials that have been performed in these diseases, and more so than in eGPA, although clearly there are more and more trials being done in eGPA now. So there's quite a bit of controversy around plasma exchange. There is a new therapy called avacopan. Of course, rituximab we use more and more, and there are newer approaches. So I was just going to cover those areas. And if we go to the next slide, please. So, of course, these are ANCA-associated vasculitides. We're talking about microscopic polyangiitis and granulomatosis with polyangiitis, what used to be known as Wegener's granulomatosis. Easier to diagnose ANCA-associated MPA and GPA because of the strong association with ANCA. ANCA is a very easily available blood test, and it has a high level of sensitivity and specificity for these conditions. So it is very useful indeed for GPA and MPA, and as we've heard, less patients positive in eGPA, but for GPA and MPA, most patients have a positive ANCA test at diagnosis, although not 100%. And GPA is normally associated with PR3 ANCA, so proteinase 3 ANCA, and MPA more commonly associated with MPO ANCA, although a proportion do have a PR3 ANCA. So when we're dealing with these conditions, there is often a delay in diagnosis, and that's probably the most important thing as doctors for us to consider is the diagnosis. If we don't recognise patients' clinical phenotypes, we then don't do the ANCA test, and then we don't make the diagnosis. So it's a really understanding that these conditions are perhaps not as rare as they used to be thought, and then making the diagnosis, getting on with the treatment. And the treatment is broken down into two phases. First of all, getting patients into remission, so remission induction, and that's usually treatment of for 3 to 6 months, and then they are treated with remission maintenance therapy for the rest of their lives, because these are chronic relapsing and remitting diseases. But that does not mean patients have to stay on treatment for their whole lives, and they have periods on treatment, periods off treatment for their entire life, but they should be followed up because there is always a relapse risk. So they should be attending medical clinics. Go to the next slide. So, of course, they are clinical syndromes. We've heard all about eGPA. So, but just focusing on GPA and MPA, we know GPA is associated with upper and lower respiratory tract granulomatous inflammation, as well as vasculitic inflammation. We know that the kidneys are the most common or severe organ involvement, with 70 to 80% of patients having renal involvement in GPA, and then 80 to 90% in MPA having renal involvement. So really important to look for kidney involvement. And so we recognise clinical phenotype, and then that should make everybody think, okay, we would do the ANCA blood test, and that's where the serology is incredibly helpful and really makes the diagnosis perhaps easier than eGPA because of the high level of association with ANCA positivity. But of course, the histology is important where there's diagnostic uncertainty, and it's really important to exclude other causes. So key mimics that can confuse diagnosis are infections, so tuberculosis or any other chronic infections, as well as acute infections, and malignancy. And once we're happy there is no malignancy or infection, and the ANCA test is positive, we can reach a diagnosis of MPA or GPA. So if we just go on, and just again talking about the time to diagnose, it's really, really important to diagnose patients early, and that's where recognising subtle manifestations and not waiting till the disease is fulminant is very important, because we know that detecting organ involvement early really changes patients' outcome, because you get the treatment going and they get better quicker. And so, for example, with the kidneys, patients presenting with a GFR less than 50 are much, much more likely to end up on dialysis. And that's sort of mirrored by the histology patterns that you see. There's a classification score, the burden classification, which is according to the different patterns of glomerular involvement that are observed. So patients who have more than 50% sclerosis in their glomeruli and their kidney biopsy progress to end-stage kidney disease much quicker than those who have a focal histological pattern, which is where more than 50% of their glomeruli are normal. So really important to identify patients, and so that's sort of looking for blood and proteinuria. Kidney function can be normal at presentation. Not all patients with kidney involvement present with rapidly progressive glomerulonephritis, and so looking for the blood and protein in the urine, doing the ANCA test, and doing a kidney biopsy to help make the diagnosis are very important. So next slide, please. So again, this is exactly the same with lung involvement. So, I mean, we've all heard about severe pulmonary hemorrhage, and that's a very frightening scenario when it's fulminant, but pulmonary hemorrhage can be quite subtle. So in these pictures, I don't know if you can see at the bottom left hand picture, there's very subtle ground glass changes in the first picture, which is sort of slightly white areas within the lung parenchyma, and that often can mean that patients present with a mild breathlessness, or they can present with just a drop in their hemoglobin, some anemia, some iron deficiency, and it can be really very subtle. And again, just they may be systemically slightly unwell, do the ANCA test and it's positive, and that, if you get on with treatment quickly, prevents it from becoming a fulminant presentation. So you can see in the next CT scan picture, there's a very severe lung hemorrhage with classical peripheral sparing of the lung parenchyma, and that patient would be ventilator dependent, would be straight to intensive care. The other lung manifestation that can be very, very severe and require chronic oxygen dependence is UIP. And this is usually associated with microscopic polyangiitis. Again, this can start in a very subtle way, and patients may not even have significant breathlessness. And in the CT scan, on the right hand side, there's two. The first one shows very subtle, sort of a moth-eaten appearance around the edges of the lung, and that's the sort of initial UIP. And if this is untreated, undiagnosed, it can progress, and there's destruction of the lungs. And the patient on the far right will be chronically oxygen dependent at home and very restricted. So again, that's really important to diagnose early and treat. So again, it's a bit like with EGPA and checking the troponin, making sure you identify the myocarditis. It's so important to diagnose these subtle manifestations, treat early, get the patient better, get them into remission, and then they go back to leading a very nearly normal life. Okay, next slide, please. Okay, so the treatment choices we have for these diseases are we have a really good evidence base, and there's ongoing trials to try and improve our treatment options, which is really great. And the way treatment works for GPA and MPA is that it's broken down according to how clinical trials have been set up, which is either for milder, limited disease or severe disease, and by that we mean where there's major organ involvement, kidney, lung, or organ or life-threatening diseases where people are imminently going to die or need dialysis unless you treat them very quickly. And that's how clinical trials framework has been performed, broadly speaking, to sort of according to disease severity. But of course, in real life, in clinical practice, it's often not that straightforward, because there are different age categories. So very old people may be excluded from clinical trials. Patients with lots of comorbidities, such as diabetes, heart disease, can be a very high risk of having complications, and there can be very frail patients as well. And so in real life, in clinical practice, we have to sort of use our clinical trial evidence, but also consider the patient in front of us. And that's where clinical practice guidelines are incredibly helpful. And KDIGO published guidelines in 2021, and ULOB guidelines are due to be published imminently. And these guidelines really help let us make sense of the clinical trial data. So if we go on to the next slide. So for years and years, cyclophosphamide has been used, and but rituximab, we have really good trial evidence to say that it is can be used as an alternative to cyclophosphamide for severe GPA and MPA to help get patients into remission. So this is for remission induction. Rituximab, it has similar outcomes in terms of remission rates to cyclophosphamide. This is data from the RAVE study. Most clinical trials look at remission in terms of BVAS score, so the Birmingham Vasculitis Activity Score, and in patients going from a high BVAS score to 0 or very low BVAS score being in remission. The BVAS doesn't really include what happens in terms of kidney function in the score. So it is important to sort of reflect on what happens in terms of GFR in patients receiving both drugs. And in fact, in the RAVE study, GFR improved in a similar way in patients whether they receive cyclophosphamide or rituximab. So that gave confidence to use rituximab in patients with kidney involvement. The RAVE trial did exclude the most severe patients who come into hospital who are dialysis dependent, have a very low GFR at presentation. So we just go on to the next slide. So the Rituximab study, which I was involved in, was a study which did include those more severe patients. It was a small study, so it didn't provide a large evidence base. And rituximab was used with 2 doses of cyclophosphamide, so it was combined with cyclophosphamide. But the outcomes were very similar between both groups, and again gave a bit of confidence to use rituximab, but not as big an evidence base as with cyclophosphamide. But other groups have looked at, can we use rituximab in the most severe patients? And there's another study here on the right, which has shown that improvement in GFR is very similar between rituximab and cyclophosphamide. So we just go on to the next slide. So those studies were, quite a long time ago, and so in clinical practice, we now can use rituximab or cyclophosphamide for patients with major organ involvement in GPA and MPA. There are other treatment options that are available. There are mycophenolate was considered quite a few years ago. There was quite a lot of interest in it because there was similar outcomes in lupus nephritis between mycophenolate and cyclophosphamide, and people were moving over to using mycophenolate. So we consider this for ANCA vasculitis, and whilst it does, mycophenolate does appear to allow patients to go into remission in a similar way with to cyclophosphamide, the relapses in patients who receive mycophenolate are greater. So there does need to be caution applied to using this treatment for patients presenting with a new diagnosis of GPA or MPA. And also in this trial, high dose glucocorticoids were used. So really mycophenolate should only be used if you're prepared to give high dose glucocorticoids to the patient. And essentially it is reserved as a second or third line agent after cyclophosphamide or rituximab, which are the standard of care. So if we just move on to the next. So I think, as I mentioned, there's a remission induction. Then after remission induction and patients go home and they're seen in the clinics, how do we keep them in remission? And 2 key trials have demonstrated that rituximab is a very good remission maintenance agent for both GPA and MPA patients. So most of these trials group GPA and MPA together. What we saw in both the Médecine and the ritazaram trial is that rituximab was superior to azathioprine for maintaining remission with less relapses over time. Both trials used intermittent fixed doses of rituximab dosing, which in clinical practice is very practical because you can just plan a patient coming back after a 6-month time period or a 4-month time period. In Médecine, it was 6 months and a lower dose of 500 milligrams. And in ritazaram, it was a shorter interval of 4 months and a higher dose of 1 gram. So there are slightly different maintenance strategies, but rituximab is widely used as a remission maintenance agent and has better outcomes than azathioprine. So if we just go on to the next slide. But there are ongoing challenges. So we can see that we've got good drugs for remission induction, remission maintenance, but there are still a proportion of people who fail to go into remission or relapse early. So that's about 10% of our patients, and we have to make sure we look after those patients properly. And there's patients who have very severe disease, who are on intensive care and are very sick, and those patients, we need to get them better quicker. We also have a lot of problems with glucocorticoid use in these diseases. High-dose glucocorticoids are associated with significant infection rates. And the other big issue that we have is, although I've just said rituximab is a great drug, we can dose it frequently and keep people in remission better than with azathioprine. Using rituximab again and again, it does have a long-term impact on humoral immunity because it is a B-cell depleting drug. So these are the areas that we're really focusing on in terms of improving outcomes. And if we just go to the next slide. So first of all, considering those 10% of patients who failed to respond, what can we do to get them better quicker? So if we go to the next slide. So one approach would be to combine rituximab and cyclophosphamide, and this is where practice guidelines do now sort of take this into account. So for example, if a patient isn't getting better on cyclophosphamide, you can switch to rituximab, and if a patient isn't getting better on rituximab, you can add in cyclophosphamide. So, and the truth is in practice that whilst patients usually start on rituximab or cyclophosphamide, it is okay to add in the other drug and use them in combination. And I think there is also evidence from various sources that if you use the two drugs together, patients may stay in remission for longer, have less relapse rates in later down the line. And this is some data that's shown that on the left. You can see lower relapse rates when you use both drugs together up front. But it's not to say that that's without risk. And so that's why practice guidelines suggest using rituximab or cyclophosphamide, but it's really only combining them for those 10% of people who fail to respond adequately to either of the drugs, because both drugs are associated with an infection risk. And we saw a lot of severe adverse events, high infection rates when these drugs are used with high-dose glucocorticoids in the rituximab trial in the sick population. Okay, next slide. So yes, we talked about those 10% who failed to respond to one or other drug, and now getting patients better quickly is a really important a goal for those who are very sick when they present either with pulmonary hemorrhage or a rapidly progressive glomerulonephritis. So if we just go on to the next slide. So this is where there's been quite a lot of discussion about plasma exchange, because back in 2007, a trial was published called MEPEX trial, which was a 100-patient study, but it was a short follow-up study, but it nicely showed that patients on plasma exchange who were given plasma exchange with GPA or MPA were more likely to get better and recover from needing dialysis than patients who just had methylprednisolone but no plasma exchange. But then that was really for only patients with the most severe kidney involvement with a creatinine greater than 500 micromoles per litre at presentation. So, a much larger study was published in 2020, which was comparing plasma exchange to no plasma exchange in just over 700 patients, but this study included patients with more a wider spectrum of kidney involvement and not just the most severe end. So they included any patients with a GFR less than 50, and it also included patients with pulmonary hemorrhage. And actually, this trial has caused quite a lot of discussion about plasma exchange, because the primary endpoint was negative, which was difference in dialysis dependence or death. There was a trend at the beginning to a benefit of plasma exchange, but that was only a trend in a large study, and it didn't pan out to be meaningful for the primary endpoint. So that did raise some questions, and there's been a lot of discussion about this trial. So if we just go on to the next slide, and I think the truth is that it's reduced the use of plasma exchange, but we still have you know, the MEPEC study, which showed benefit in the patients with the worst kidney involvement, the most to lose by staying dialysis dependent, and the greatest to gain. And so following on from the negative PEXIVAS study, a meta-analysis has been performed of all plasma exchange studies, and overall, there is a small benefit associated with plasma exchange that came out of this meta-analysis. And looking into the data in more detail, the greatest benefit appears to be those with the lowest GFR at presentation. And so this is where recent guidelines are saying that plasma exchange can be considered, but in those with the lowest GFR. So plasma exchange is still used in these patients. So if we just go on to the next slide. But its use is more restricted than perhaps previously. So the other issue I've mentioned is all our high use of steroids in our patients. Many clinical trials have used high-dose glucocorticoids, and we know that when patients come into hospital with a new diagnosis of GPA or MPA, they can be very sick. And this is not just the vasculitis, but it's superadded infection. And nearly half the deaths that occur in ANCA vasculitis are associated with infection. So anything we can do to lower infection risk is really important, and tackling high-dose glucocorticoid use is very important. So if we just go on to the next slide, and this just makes the point, this is an old study, but it just makes the point that if patients have infection, they are much more likely to die than if patients don't have infection in ANCA vasculitis. Okay. And so in the PEXIVAS study, which we've talked about, which is the plasma exchange versus no plasma exchange study, the design was a factorial design. So they answered two questions. One was about the benefit of plasma exchange, but the second question was about using less steroids. And this is the first clinical trial in ANCA vasculitis that considered a lower dose glucocorticoid regimen compared to a standard dose. So patients were randomized to plasma exchange or not, and then re-randomized to standard dose or reduced dose glucocorticoids. So we just go on to the next slide. So you can see that there was a much more rapid steroid taper, and this is prednisolone doses in milligrams. And as you can see, sort of goes, broadly speaking, patients started at the same dose, but then by week 12, they were on half as much. And what the PEXIVAS study showed, which included, patients with severe disease, is that there was no difference in the primary endpoint of death or end-stage kidney disease, whether they had the standard dose steroids or low dose steroids. And so this, but there was a reduced incidence of serious infections in the patients who received the lower dose steroids. So this is actually really important data for clinicians, and it's given confidence to use less steroids treating these patients when they come in, which is really good news. So just go on to the, thank you. And there's also been another study called LOVAS, which was a Japanese study published last year, which used an even lower steroid dose in these patients, which is quite significantly lower than patients have been typically treated with in the past. And this was combined with rituximab. And the patients in this study did just as well in terms of remission rates, and relapse was only slightly higher in those who had less steroid. But you can see that the cumulative steroid dose really was significantly lower in the low steroid group. I think the thing to say about this study is that these patients were perhaps less severe than Pexivas patients. So it is not recommended that all patients receive this low VAS steroid regimen, and the Pexivas reduced steroid dose regimen is the one that is now really recommended. So if we just go on to the next slide. So again, talking about glucocorticoids, another very exciting therapy that's really just coming out in terms of clinical practice is avacopan, which is a drug that targets C5a. So it's a complement inhibitor. Why would we want to use this drug? Well, I suppose going back to the pathogenesis of ANCA vasculitis, it's a inflammation of small blood vessels with a neutrophil-rich inflammatory process. So there's neutrophils around the vascular endothelium. We just go back, yeah. So what we know in ANCA vasculitis, the neutrophils go up and surround the blood vessels, having migrated through the blood vessel wall and damaged the vascular endothelium. And we know C5a is a very strong neutrophil chemotactic factor. It causes neutrophil priming and migration to the vascular endothelium. And so by blocking C5a, there may be a beneficial effect. So if we just go on to the next slide. So the Advocate trial was a trial that was recently published, and it is the first disease that this drug was used in, though it is now being trialled in multiple other conditions. But the Advocate trial was a phase 3 trial that compared avacopan, a C5a receptor antagonist, to a placebo. But also compared it to prednisolone. So slightly complicated design, but essentially patients in the avacopan group received the avacopan tablet twice a day, and patients in the placebo or the non-avacopan group received prednisolone, tapering down and being reduced over a 6-month period. And all the patients also got either cyclophosphamide or rituximab as chosen by the doctor putting them into the trial. So if we go on to the next slide. And this was a very exciting study because it was positive, and that avacopan was group had very similar remission rates to prednisolone at week 26, so was non-inferior. But when avacopan was continued out to 12 months, so at the end of a year, patients who stayed in remission with avacopan were actually, avacopan was better than prednisolone. So if we just go on to the next slide. So, and as a kidney specialist, for me, this is really exciting data, because not only was avacopan a way of replacing prednisolone use, but it also was associated with better improvements in kidney function. And again, going back to the point of patients getting better quicker, this is and being more likely to recover kidney function. This is quite exciting data. So if we just go on to the next slide. So I think we've just seen, that we can use less steroids than we used to, and also use a newer drug, avacopan, that has received approval for use in this disease, which is helping us to use less steroids again. So the other main area of issue for me as a clinician and for everybody who treats these patients is how do we handle the impact of rituximab on humoral immunity and infection risk? And if we just go on to the next slide. Rituximab, as I've said, is, shown the data is a great drug for ANCA vasculitis. It really helps keep people in remission long term by repeat dosing, as well as getting them into remission in the first place. But every time we use an immunosuppressive drug, we have to weigh up the pros and cons. And of course, we don't want organ damage, but we equally don't want to give so much immunosuppression that we cause treatment toxicity, infections. And for these drugs that, like rituximab, that target the B cell pathway, there's concern about impairing vaccine responses. Just next slide. So of course, COVID-19 has been a very big issue. And of course, COVID vaccination is very important. So I think the truth is for ANCA vasculitis, when patients are sick, active disease, and if you want to use rituximab, then that is the balance nearly always favours using the rituximab, because you have to treat the patient, you have to get them better. But then when patients are in stable remission, and you want to redose rituximab on a regular basis, often we should be using rituximab because they need it, but it's not always the case. And you do just have to think about, what is their infection risk, and is this the right decision? So if we just go to the next slide. And this is where we have to think, what is the infection risk of the patient? So this is a study we did in Cambridge where we tried to group patients according to their infection risk. And we found in our study that patients who have damaged lungs, usually as a result of vasculitis, but certainly they have structural lung disease, or they have diabetes, or they've got a prior history of infections, or they've got a low IgG level, those are the patients who are prone to getting more and more infections as you go on with treatment. So those are the infections that you might think twice about. Those are the patients that you might think twice about giving more rituximab to. And you can separate patients into two groups according to these risk factors. And if we just go on to the next slide. And as I've said, IgG is quite important to measure because patients, a small proportion of patients do become chronically hypogammaglobulinemic after rituximab. Now, a lot of patients will get a transient hypogammaglobulinemia, which is shown in the graph on the left. The IgG goes down, but then it bounces back up. But about 20–25% of patients will receiving regular rituximab will stay with a low IgG level, and in some patients it becomes very severe and they need replacement therapy with immunoglobulins, which of course is very expensive. And so those are the patients you really just have to think, should we be carrying on the rituximab? We also know that COVID vaccine responses are impaired in rituximab treated patients. So again, this is just another consideration. And we know that at the beginning of the pandemic, rituximab use was associated with a higher odds ratio of death when in patients with having COVID infection. Although that is old data now, because of course now people have been vaccinated. Now there are now treatments for COVID available. The risk of death is much lower. So the situation is improving and changing all the time, but it's just something we have to be careful with in clinical practice. And it's not just COVID; it is recurrent infections of any cause. So if we just go on to the next slide. So I've talked about infections and I've made it sound quite negative, but it shouldn't. It just means you just have to select your patients correctly. There are some patients who will relapse multiple times again and again with their vasculitis, and you just have to work out which ones would really benefit from rituximab. And that's where we know certain features predict relapse. We have PR3 ANCA, patients are much more likely to relapse than MPO. GPA patients are more likely to relapse than MPA patients. We know patients with ENT involvement, those with better renal function, and those who have less cyclophosphamide exposure and have their steroids withdrawn early. So those people are more likely to relapse, and so they may need to have repeat rituximab dosing. So if we just go on to the next slide. And the other thing that predicts relapse in rituximab patients is if patients' ANCA stays positive after receiving rituximab treatment, and indeed if their ANCA starts to rise, and also if their B cells return in their blood quickly. So these are things that we can measure in clinical practice and help predict relapse. And these are incredibly important. The ANCA measurements and the B cell measurements are incredibly important if we are considering stopping rituximab. So I think that's a very important point. After we've given a 2-year course of these drugs, how do we monitor patients? And we do need to counsel them about their risk of relapse, consider their infection risk, and keep a close monitor on their ANCAs and B cells, because essentially if they're stopping treatment, they're coming off immunosuppression, and they do need to be monitored. So if we just go on to the next slide. So I've talked a lot about treatments. So those are the standard treatments and how the practice is changing to less steroids, repeat rituximab dosing for those that need it. But there are other approaches to try and reduce rituximab use, which is combining other therapies. So one trial we're doing in Cambridge is looking at belimumab with rituximab. We've heard of belimumab because that's now used for lupus patients, and it's associated with falls in double-stranded DNA. And we know that ANCA staying positive in ANCA vasculitis predicts relapse, and we would like to get more patients ANCA negative. So belimumab, which is inhibits the main B cell activatory cytokine BLyS, is used in lupus and is being trialled in this study in ANCA vasculitis, combined with rituximab to get better B cell depletion, with the hope of getting more patients ANCA negative. So that's just another thing that's going on. Next slide. So that's study is finished recruitment, and we go on to the next slide. There are, and of course, other approaches to try and avoid steroids, reduce relapse. There are other trials going on. So this is a study on abatacept, which of course you're familiar with in rheumatoid arthritis, and is a T cell targeted therapy. Of course, T cells are very important in the pathogenesis as well, and it's a drug that causes T cell silencing or T cell anergy. And there was a small study that was positive from the US, and which has led on to a larger study called the Abrogate trial. So again, it's completely different pathway to some of the other targeted therapies that are being used. But again, the concept behind this study, which is targeting the less severe patients, is a way of reducing glucocorticoid use and putting in the abatacept to treat minor relapses, and comparing it to placebo, and seeing if we can use less glucocorticoids for minor flares of GPA. So that data hasn't come out yet. And if we go on to the next slide. Yes, so again, so we talked about avacopan being a C5a receptor antagonist, again, a very different target, being useful for getting patients into remission, which is what the Advocate trial focused on, but also very good for remission maintenance. And so again, this is another way of using less prednisolone and actually being perhaps better than prednisolone. I think what we should caution people about, because this is new data, is that avacopan hasn't been directly compared to rituximab maintenance. So we can't say it's compare it to rituximab maintenance, but it is an alternative to using prednisolone long term. Okay, next slide. How am I doing for time? Okay, so really, I haven't put all the EULAR and KDIGO guidelines there, but the summary is of our current practice. first of all, really important to diagnose the patients, identify them early. For our treatment of the patients, we have remission induction, which is either rituximab or cyclophosphamide first line, with lower dose glucocorticoids than we used to have to use. We can use mycophenolate, but that's very much second, third line. Plasma exchange, there's less evidence. The evidence is weaker for all patients, but there's still a role of plasma exchange, and it can be considered for patients with the most severe renal involvement at presentation, or severe pulmonary hemorrhage. For remission maintenance, we know that rituximab is definitely better than azathioprine for preventing relapses, but we should be mindful that if we're stopping the rituximab after a 2-year course, then we have to monitor patients for relapse, because some relapses can happen, and measuring B cells and ANCA, counselling patients, very important. If we are using rituximab long term, we should just balance the decision against how high risk is the patient of having an infection. Next slide. So just to finish, we are pleased that we can use less steroids. That's a new thing that's come into our practice over the last couple of years. We're very pleased that avacopan has been approved as a new drug for this condition. And I don't know how it is in France and other countries, but in the UK, we haven't yet got avacopan in our clinical practice widely, but it is something that we're hoping to get very soon. And understanding where best to use avacopan will be very important. For remission maintenance, we know rituximab affects the humoral immune system, so we just have to be careful we choose the right patients for the drug. And that's where I'd like to end. Thank you.
Thank you, Dr. Jones, for the presentation. I think it was a very clear and well-structured presentation. I highly appreciate the content. So we will give the floor for the audience for their questions. I will start maybe with my own questions. And the first question is addressed for both of you, Dr. Terrier and Dr. Jones. It's regarding peripheral neuropathy. It's not part of the FFS score, but do you consider it an indication for cyclophosphamide or rituximab treatment? Should we consider it as a severe form of vasculitis? Maybe you can answer this question first.
So I think you answered this question, didn't you, Benjamin? But that you, the question was about using cyclophosphamide for peripheral neuropathy.
No, I totally agree that, and it was probably the main involvement explaining why in France, the country of the 5-factor score, we decided to remove the use of that in GPA and MPA. It's because, when it was designed for the young internist 25 years ago, the aim was to save the life of the patients. Now, based on the use of rituximab, of better cyclophosphamide regimen, clearly the patients were dying less, which was a very good news. But it was not, very good achievement to not try to get, the best prognosis for the patient, and especially the functional prognosis. So that's why I think severe forms of multiple mononeuropathy can be really, really painful and disabling for the patients. And that's why in the distinction of severe and non-severe, we decided, like the colleagues in UK or US, to consider that the severe manifestations could be a functional involvement and not only a life-threatening manifestation. So clearly, we consider now that you have a severe multiple mononeuropathy, it's clearly an indication to consider that it's a severe disease. And I think, Rachel, we were mainly using the FFS before, but you were doing like that for a long time, no?
Yeah, and I suppose I think it's a good point for not only peripheral or mononeuritis multiplex, but it's for other manifestations now. There's become a lot more flexibility in terms of what you call severe and what you call non-severe. So, you know, I suppose for things like even ENT involvement, which is traditionally considered, and I'm talking about GPA and MPA more here, GPA really, but you know, ENT involvement was always considered non-severe, but you know, you can have very, very destructive nasal disease, and you know, people can sort of have their bones destroyed, and in that situation, that's clearly not non-severe. It's clearly severe. So, and I think, you know, that's where more flexibility has been allowed in terms of all our scoring systems. We can upgrade items if we think they meet they're bad, and I think that's the right way to be across clinical practice for whether it's ENT or, you know, even cutaneous manifestations can be horrendous. You can get, you know, really bad ulcers. So I think it's sort of understanding what that is, sight-threatening disease as well. You know, things like that. So I definitely agree with the mononeuritis multiplex. I mean, that's very debilitating. But it's across the non-severe manifestations. We should always, you know, keep an open mind and use cyclophosphamide if we think they are severe.
Thank you for the answer. My second question comes from, maybe it would be representative for many participants here, is that, for example, in my country, access to biotherapies is very difficult. Sometimes some molecules like belimumab, we don't even have them. So you talked about the association of cyclophosphamide with rituximab. Do you have any information or data about the association of MMF with the cyclophosphamide for very severe renal manifestations? Is that a possible alternative?
Well, yeah, I mean, I think that's a slightly different question. I think you're saying add mycophenolate and cyclophosphamide. I think that would be quite difficult to do. I wouldn't recommend it. I think it's, you know, both of them cause lymphocyte suppression, and I think we'd run into severe infection risks if we did that. I think the reason people put rituximab and cyclophosphamide together, because although I fully appreciate cyclophosphamide causes B cell suppression, you know, rituximab is only causing B cell suppression, and so you're not getting a sort of pan lymphopenia. We have to manage cyclophosphamide carefully, is the truth. We all know that. We have to give patients Septembre prophylaxis. We need to make sure that we don't overdo it in terms of white cell count, lymphopenia. But I think you can use the rituximab and cyclophosphamide together, because it's, but I think long term, I think it would be very complicated to use mycophenolate and cyclophosphamide together. I think if you had a refractory patient to cyclophosphamide and you didn't have rituximab available, which is, I think, what you're saying, is that your question? What can you do if you don't have easy access to rituximab?
Exactly, yeah.
Yeah,
Yes,
I mean, one thing I would question is the cyclophosphamide dose. I think, you know, if you use IV cyclophosphamide, and if you stick with the Cyclops protocol, where there's a cap, there's a limit to the maximum dose. Sometimes what we do nowadays is underdose people. So I think it is reasonable to reconsider whether you have the best dose. I think adding cyclophosphamide, adding, you know, that's where you might turn to plasma exchange if you have access to that, if you don't have access to rituximab. I think with the pricing of rituximab has improved significantly. So this is a question I suppose back to you, is whether rituximab it's a price that prohibits it, or because these days it's less expensive than it used to be. But I don't know how that works in every other country.
It's a question of budget in Tunisia, for example, because we have to do very complicated administrative procedures that most of the time the insurance institutions do not accept them because of the high prices.
Mm-hmm.
So it's not easily accessible. Even if we get the rituximab, usually it takes time to get the approve, to get the.
I see, it's a delay.
Yeah, exactly.
Yeah. Yeah. I don't know. I don't know, Benjamin, but I feel a bit uncomfortable using mycophenolate and cyclophosphamide together. I think I would rather use more cyclophosphamide and than combine the drugs where you don't quite know what's working when, and it's the monitoring, unless I had a lot of experience with it.
No, I totally agree that I think in refractory patients, we either have the combination of drugs, and especially now it's the combination of rituximab and cyclophosphamide. But what was a good alternative before, when we did it before the rituximab era, was to switch the cyclophosphamide from the intravenous form to the oral forms. And as if you do the calculation, the cumulative dose was much higher with the oral dose, because it was something like 2 milligrams per kilograms and per day every day. So after 1 month, it was a very important dose. And I think the Cyclops study was very important because it showed that you could be as effective with intravenous and without with limited toxicity. But we still consider, but it became really rarely in the rituximab era, that oral cyclophosphamide could be an option. And I think that in countries in which you can have the access to biologics, in case of refractory disease to cyclophosphamide intravenous, switching to oral for maybe 3 months, usually it was maybe from 3 to 6 months, it could be an option. But of course, the toxicity was also more important. It was when we were seeing some bladder cancer, hemorrhagic cystics. So I think but it's an option.
Yeah, I completely agree. I think, yeah, it's difficult, but
hopefully these patients are not so frequent.
Yeah, I mean, honestly, in my clinical practice, I use rituximab and cyclophosphamide combined a lot. I find that they are a very, very helpful combination. If you are able to gain more easy access, it would be helpful for you.
Yeah, thank you for the answers. Romain, do you have questions before we go to the audience questions?
We can't hear you, Romain. Yeah.
Okay. Just in terms of cardiovascular risk factor management, could it be interested to use SGLT2 inhibitor to prevent cardiovascular risk factor, and also to prevent a decrease in renal function in terms of the management for long term?
Yeah, I mean, it's a great question because it's quite topical. Because of course these patients were excluded from the DAPA-CKD trial. But there is, definitely a role for SGLT2 inhibitors in CKD patients, and I think more and more we're using them, but we don't have a really good database in ANCA vasculitis, is the truth. And so I think I would use them. There's increased cardiovascular risks in ANCA vasculitis. So yeah, I think they are becoming more and more used. But these patients, we don't have a good evidence base for. Is that fair?
Thank you.
So we proceed with the audience written questions. So the first question is about the Plexivast protocol for glucocorticoids. So the question is, beyond the studies, would you recommend the Plexivast reduced dose glucocorticoid regimen? And does lowering glucocorticoid dose regimens appear in the next LR recommendations? This question is for you, Dr. Terrier.
So, yeah, so clearly, and I think Rachel talked about that, and especially because you see the low VAS, study, and Rachel presented this study published in the JAMA. And what we can say in the EULAR, the recommended regimen would be exactly what Rachel recommended, so the low-dose Plexivast regimen. So in fact, in the EULAR recommendation, we did not talk about the low VAS protocol, probably because the patients were less severe, like Rachel said, and also, because there is some question about the pharmacokinetic of between Japanese people and European people. So I don't know exactly why we do not talk about at all of the low VAS protocol, but clearly the new gold standard in terms of glucocorticoids regimen is the low dose the low dose Plexivast.
I think the truth, it's a very big study, Plexivast, isn't it? And it gave a lot of certainty about the fact that it was safe to reduce the steroids. I think the low VAS study is quite a lot smaller, and as you said, in maybe a slightly different population. So perhaps that would be reducing. We don't have enough data, but there's good data from Plexivast. Yeah.
Dr. Terrier, you have a question to Dr. Jones?
Yeah, thanks a lot, Rachel. In fact, I would like to know what you think, because and I think it was confusing for people, and I talked of that with David. Is before Plexivast, plasma exchange were recommended for patients with creatinine level greater than 500 micromole per liters. As you may know all, Plexivast was a negative study for plasma exchange, but it was a very important study for the glucocorticoids. And in fact, at the end of that, the new EULAR recommendation will say that we have to recommend plasma exchange for people with serum creatinine greater than 300 micromole per liter. So in fact, it's like if plasma exchange were now more permissive after Plexivast than before. What was something confusing, because I think we had, we put the plasma exchange in the trash after Plexivast, but in fact it's coming back into the game. And so I wanted to ask you, Rachel, about this threshold of 300. Do you think we should adapt according to the results of the renal biopsy? Because from the MEPEC study for the young internist, in fact, there was not always a good correlation between the value of the serum creatinine and the status in the kidney, between fibrosis or active lesions. So what would you do? Would you recommend to do a biopsy each time you can, or would you maybe just only use the serum creatinine level to consider plasma exchange?
These are really good questions, and these are questions we get asked every day. So I think, as you know, it's complicated with kidney biopsies, because you have to, the patient needing plasma exchange can be quite sick, and they may not be fit enough for a kidney biopsy. So by the time you've waited for a kidney biopsy, you've not done the plasma exchange. So it's often you don't have the choice. It is just do the plasma exchange or not do the plasma exchange. And so this is where I think we can't rely on kidney biopsies. I think in MEPECs, the biggest thing that came out as a predictor of good outcome was the percentage normal glomeruli. And of course, there's different ways of looking at histology, but that's probably the strongest. The two things are: what is your baseline creatinine? What is your percentage normal glomeruli? I think that the recommendations are probably right to choose a creatinine because it's something that we all understand. It's easy. We have the result. Whether 300 is correct, I don't know. I feel comfortable with it because it gives me an option to use it if I want to in patients above 300. But I think, what I really hope we get from Pexivas is more detail in terms of the analysis. And this is where, before the trial was designed, as you know, there were primary endpoints, secondary endpoints. But what we really want to know is subtle, what changes in GFR in patients with different baseline creatinines and what that creatinine means. So I think Mike Walsh, as I'm sure you know, has presented some data that the patients who benefit the most are the patients with the worst kidney function, and so it's sort of incremental benefit, and you still have to treat quite a lot of patients to save one person from. So it's not, if you treat everybody, they will all benefit. So I think the answer is it's not the best therapy. It's a therapy. And I think if we have patients with creatinines above 300, we can consider the therapy. I hope that we get more data with avacopan, as I'm sure you do. The avacopan excluded patients with GFR less than 15. And actually, that might be where avacopan is incredibly helpful. But there isn't currently a study comparing avacopan and plasma exchange. But that would be very interesting to see that sort of data, because actually, of course, if we can just give someone a tablet and it gets their kidneys better more than plasma exchange does, that would be amazing. So sorry, I haven't really answered that, but I think it's a difficult one. But I'm glad that I still have it as an option.
No, I totally agree, and thank you for your reply.
One other comment on that: I think there is a danger in people not using it or not considering it, and that's why I'm glad it's in the recommendations, because if it wasn't in the recommendations, people wouldn't use it at all. So I think it's positive it's in the recommendations.
So the next question is about hypoglobulinemia when using rituximab. So at what level of gamma globulinemia do you recommend immunoglobulin supplementation?
So I don't think there's an absolute level, because some people become quite severely hypogammaglobulinemic, and by that I mean less than 3 grams per litre or 2.5 grams per litre. But they may not be having recurrent infections. So the point is, it is for people who are having recurrent infections and hypogammaglobulinemia and are already on antibiotic prophylaxis. So, first thing to do is put patients with recurrent infections on antibiotic prophylaxis. And second thing to do first thing to do would probably stop the rituximab. But then if, they continue to get infections despite stopping rituximab and, having the antibiotics, then we have an immunology team who decide, but we refer to the immunologists. Yeah. So, but in general, if a patient's IgG is falling, and I find it very helpful to graph, what's happened over a few years, and you can see it's just going down, 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 down. I suppose, there isn't an absolute level, but I do get worried when it's just falling less than 5 grams per litre. So when it's moderately severe and it's not stable, but it's going down, because I think that's going to get worse. So that's when I'd think about stopping the rituximab and considering an alternative maintenance, or perhaps they don't need a maintenance therapy. I don't know. What do you do, Benjamin?
No, I totally agree with what you said. And in fact, it's completely, the French recommendation we have, because the use of intravenous immunoglobulins is really, really restricted in France.
Yeah.
And so you said, I think, all the key points. So it means that you have to have recurrent infection and a failure of antibiotics. And when we see the recommendation from the French treatment societies, ANSM, it's exactly what we have to have to discuss to use immunoglobulins. So I think, I think it's the really good way to do.
Okay, I think we had the answer for that question. The last written question we have is, where would avocapan be considered in the ANCA-associated vasculitis treatment strategy when compared to rituximab and cyclophosphamide? So if you were to form a recommendation, even though no direct comparison has been conducted, what would you recommend?
Oh, okay. So I think, was the question whether you should use it with rituximab or with cyclophosphamide, or because of course the clinical trial you could use rituximab plus avacopan or cyclophosphamide plus avacopan. So I think you can use it. I think the decision whether you want to use rituximab or cyclophosphamide is the same. You use one of them and then you add avacopan with that drug. Is that the question, or were you talking more about maintenance? Sorry,
I think it's about the maintenance. Omar might correct me if I'm wrong, but I think his question is about the maintenance to therapy.
Okay.
If we should keep on avocapan or rituximab.
I don't think there is a recommendation on this, but I think rituximab, in my experience, you can more or less stop steroids in most patients. And I think, a big thing about avacopan is it is a steroid-sparing agent. So I think if I was using rituximab maintenance, I wouldn't necessarily use avacopan as well. I think also the truth is, this is another expensive drug. And right now, do you need to give rituximab and avacopan? Probably not. I think there is a minority of patients on rituximab who get very frequent relapses, and maybe in a minority I would combine, but normally I would just use rituximab. I think, for example, the hypogammaglobulinemic patient who I want to stop rituximab if they have relapses, then I think that would be a very good person to potentially consider avacopan, which works in a completely different way. So that might be where we start to use avacopan for maintenance. But of course, the way it's been used in the clinical trial is part of the induction therapy. So at diagnosis and then continued into maintenance. So yeah, it's I don't feel confident to use avacopan as the remission maintenance agent in all my patients until we have more data. I don't know, Benjamin, do you have any other comments?
No, I totally agree. So far, it was only evaluated as a corticosteroid sparing agent. And we will see what the negotiation of price will do. But, for instance, for the early access to the drug right now in France, I don't know how much is that in the UK, but it's 80,000 euros for 1 year. And if you compare with the rituximab, with the biosimilar, it's just completely different. So that's why on the economic aspect, using avacopan on the long term is just it's just a drama. It's just a drama for the health insurance.
Yeah, I think that's the truth. it's the cost is going to be, you know, and maybe the cost will come down with time, but at the moment, I think cost is going to be a big factor. So selecting use will very likely be what we do.
Okay, so we're back to GPA. We have a question about it. It's about how to differentiate GPA to an essential hypereosinophilic syndrome when the clinical presentation is the same, and when biological, immunological, and genetic markers cannot help differentiate whether it's GPA or it's essential hypereosinophilic syndrome.
No, it's clear that some patients with hypereosinophilic syndrome or ANCA negative eGPA, sometimes it can be tricky to distinguish them. And clearly, I think it's only a question for the ANCA negative patients. Clearly, asthma can be found in both groups, but the frequency, the prevalence of asthma is much more important in eGPA by definition. It's something like maybe 25 to 30 patients in HES. It's almost 100% if in eGPA. And also one is a very important point to my point of view is that eGPA is a vasculitis. If you consider HES, colleagues from Lille in the north of France describe that eosinophilic vasculitis may occur in HES, but I think it has to be maybe considered like rare manifestations of hypereosinophilic syndrome. So clearly, eGPA is an hypereosinophilic asthma with vasculitis. Getting an hypereosinophilic asthma with vasculitis in an HES, it's probably something feasible in 1 out of 1,000 patients or more. But the big difference is that eGPA is a vasculitis, HES is not a vasculitis. So HES has no reason to have an inflammatory syndrome, an increase of acute phase reactants, and eGPA has inflammation, so it has an increased CRP levels, for instance. But sometimes it can be tricky. And you know, for the people from the eosinophilic world and people from the vasculitis world, in some cases, they will not be in accordance for some stories. And we see that frequently with the colleagues from the SERO, which is the eosinophilic group. Sometimes we do not have the same vision. I don't know, Rachel, if you have also in UK some people from the eosinophilic world working on HES and what they think about the distinction between eGPA and HES?
I don't think we have that much discussion between the two worlds. I think the worlds are quite different, and I think that's where, honestly, sometimes patients get diagnosed according to what people know best. But I think what you've said is absolutely correct. You know, you can more or less differentiate the syndrome in most patients, but there are a few patients where they're very similar, and you may not have histology. I mean, it's not always possible to get biopsies that, but I think usually, as you say, there's a clinical aspect, you know, some of them, whether it's the asthma or there's other things that are going on that make you think, oh yeah, this is eGPA and not just hypereosinophilia. Yeah, it's but I think, I don't know, and this is a slightly different point, but in your practice, whether it's, I found that more and more, because we're using mepolizumab, we overlap with asthma more and more. We see more and more ANCA negative eGPA in our practice because we know the asthma doctors, you know, the specialists very well, and they refer more patients to us. And so what used to be perhaps more ANCA positive, I think, you know, the sort of discussion about sort of 40% being ANCA positive, or, you know, sort of, it's, I don't know if that's even true. You kind of, it's just the more you look in the respiratory world, the more you diagnose, I think, of eGPA. I don't know if you found that you've perhaps not, because you do internal medicine and it's a slightly different practice. But in the UK, we've sort of more and more speaking to respiratory doctors and recognizing more ANCA negative eGPA.
No, I agree that it's really depending on maybe the department the specialty of your department, but clearly, and one other thing is that, since mepolizumab is more used in refractory asthma, hypereosinophilic asthma, maybe the incidence of eGPA will decrease because using more mepolizumab earlier will allow.
Yeah, very good point.
But we will see. I think we need some time to see, using the national database, if treating more efficiently the asthma and the hypereosinophilic asthma will lead to a decrease of eGPA. We'll see.
Yeah, no, that's a very good point indeed. Yeah.
I think we will end with the last written question. I will read it. So, in case of immune deficiency secondary to corticosteroid therapy with immunoglobulin at 4 grams per liter, and I need to introduce rituximab after failure of cyclophosphamide without recurrent infection, what course of action do you recommend?
Okay, so I think you're talking about a very acute scenario where the patient who's got a low IgG, but they've had some cyclophosphamide and they've had quite a lot of steroid. I think in that case, it's okay to use rituximab. I think that's why we see that kind of drop in IgG in a lot of patients, and then it bounces back up, because steroids really do suppress IgG. But when you get the steroid doses down, the IgG improves. I think that's if a patient is known to be hypogammaglobulinemic for a long time, we know that they're at greater risk of becoming severely hypogammaglobulinemic when you add the rituximab. But if they're on a high dose of steroid, then it's quite difficult to interpret the IgG because that does suppress it. Is that answering the question? I think, cyclophosphamide itself suppresses IgG as well a bit, but yeah.
I think that was clear, and I think we can wrap up. On behalf
question.
of what?
I have a last question. Just
go ahead, Mama.
What do you think about obinutuzumab, and what do you think it could be used in the future for ANCA vasculitis?
It's a great question. I think we get very high remission rates with rituximab. So do we need better B-cell depletion? Maybe yes, maybe no. I think obinutuzumab, because it's a newer generation anti-CD20, is going to allow better B-cell depletion for a longer time than rituximab. So it may be will get rid of more B cells in the tissues. Rituximab works very well in the blood in ANCA vasculitis. Sometimes we still find persistent B cells in tissues. So we might, for patients with refractory disease, get better outcomes with obinutuzumab. But I think that will be hard to prove in a clinical trial with a clinical endpoint, unless we were to look at sort of sequential need for relapse and remission maintenance. So in lupus, as you probably know, there's been a positive clinical trial in nephritis, and then now it's been used in larger phase 3 studies in lupus, and I think it's fair to say the B cell depletion with obinutuzumab in lupus has been better than with rituximab. But there's a number of reasons why that might be, but it's obviously a better CD20. So maybe is the answer yes. I think we're going to have to be careful if we're using stronger anti-CD20s about infection risk. But it might be that you could give obinutuzumab and not have to give so much remission maintenance. So it might not be less safe. So it's a good question. But we don't have any data on it right now. We're doing a very small clinical study in Cambridge looking at obinutuzumab, but it's more looking at sort of mechanism rather than, you know, how it works, rather than actual clinical endpoints.
Okay,
but of course it will be. I don't think it's that expensive actually, because it's used in across hematology indications already, isn't it?
Thank you very much.
Thank you.
Our last questions.
Yes. So I think we will end the session now. Again, on behalf of both of our associations, the Tunisian Young Internists and the French Young Internists, I say a big thank you for both Dr. Terrier and Dr. Jones for this very, very interesting and enriching presentation. You both updated our knowledge about the management of ANCA-associated vasculitis. Also, I thank you all for trying with us this new experience of English-speaking sessions. It's a learning experience for us on a scientific and communication basis, both. I hope you liked the experience. I hope the messages were transmitted clearly. So I highly thank Dr. Terrier's efforts for speaking English and answering the questions in English. Also, I thank Dr. Jones for accepting that Dr. Terrier spoke in French in the beginning. This is us being going international and fostering exchange between all parties. So I hope you had a good time, everyone, and hope to see you again in real life, maybe, or next month in our next webinar. Thank you, everyone, and have a good evening.
Thank you very much.
Thank you very much.
Good night.
Bye-bye. Bye.
Bye.
Bye, Rachel.
Bye.